I grew up in Scotland, and in Scotland, healthcare is a right. Carrying a machine gun is a privilege, and maybe you got it the wrong way around. You know, and I've been asked over the last couple of days, how exactly do you become a futurist? My undergraduate major at Edinburgh University was Geographic and Economic Change in Scotland, 1580 to 1830, which is incredibly useful. But actually, you know, it is a useful training. Those of you who know your Scottish history will remember in a very short period of time in the latter part of the 18th and beginning of the 19th century, Scotland transformed itself from being a bunch of Braveheart, Claymore-wielding maniacs to being the crucible of the Industrial Revolution and the Age of Enlightenment. As you well know, the Scots invented every important technology over the last 500 years, including golf, the steam engine, and the television. You want to fight about that, you can, but you'll lose. I will remind you that we Scots cloned the sheep. And given my countrymen's predilection for that animal, it's probably no surprise. But anyway. So I moved from Scotland to Canada in the late 70s. And in fact, I joined, that's where I met my wife, Nora, actually, who was a nurse and ended up working in the same area. This was in Vancouver, British Columbia. And I was an urban planner, but I was hired to join Management Engineering Unit 13.1, which is the Canadian healthcare equivalent of the KGB. Basically an internal systems engineering, as Dr. Curtis was talking about. And I started my career basically following anatomical pathologists in and out of morgues and OR suites, trying to understand what they did for a living and doing time and motion studies. And I attended all of the concurrent sessions simultaneously yesterday. We futurists can do that. And I was intrigued, certainly, by the lean organization and some of the work that you've done in terms of reliability, because it really is hard and difficult work to translate these lofty goals into practical changes on the ground, and I applaud you for all of that. Now, I do want to say some things about quality and point to the different ways in which different actors in American healthcare look at quality. And I want to talk about this quest for value, and particularly my good friend Ken Kaiser. He and I have been on, I think, 5 programs in the last 6 months together, so I'm going to violently agree with almost everything he said. But I will amplify this whole notion of what the consumer is expecting or experiencing over the next couple of years. And then they'll take away my futurist license if I don't share some scenarios with you at the end. The other perspective I bring, I think, is one of being a patient. 2 years ago, I had a serious medical problem. My golf game had collapsed. If you're Scottish, that is a serious medical problem, okay? And so my wife, who's an old emergency room nurse, no, I shouldn't say old, I should say seasoned, I guess is the word. She remarked that, you know, I had weakness in my legs and I'd lost so much distance off the tee and I couldn't play. And so she forced me to go back to my primary care physician, and he sent me for an MRI. Now, what a thrill for a Scottish Canadian to be sent for an MRI. It's easier for Canadians to win an Olympic gold medal in figure skating than it is to get an MRI. Nobody in Canada has ever had an MRI. My mother and sister and stepdad all live up in Vancouver. I was the toast of the extended family. And I ended up, after trying all the other alternatives, having spinal fusion C5, C6 at Stanford. All worked out fine. My golf game's, you know, decent again, not great, but I can play. I am now an apologist for neurosurgeons in academic medical centers. But I describe my clinical experience at Stanford as islands of clinical excellence surrounded by the Department of Motor Vehicles. Unbelievable. I mean, how patients get out of hospital alive is beyond me. It's the opportunities for things to go wrong are enormous. You know, I was only in there like 24 hours, and we do drive-bys in California. You know, I think I had 8 different nursing teams on the floor. I mean, it was unbelievable. So the challenges are real. All right, let me start because I do want to share with you some real data as well as just sweeping generalizations. And one of the things that we do with my partners at Harris is we ask the public how good a job is the following industry doing for consumers. Seems a sensible place to start the conversation. Americans love their supermarkets. We do a fine job of supermarkets. I actually fly a lot, and so I'm always particularly interested in airlines. We take this survey early in the year. So you'll notice here, before 9/11, this is before all the tragedy, a 20% drop in satisfaction with airlines. Now this, I felt vindicated by this. It's perfectly consistent with my experience. I'm a million-mile flyer with United. I fly 100,000 miles with them every single year. They treat me like scum. God knows how they treat the poor bastards in the back of the plane. But anyway. So you'll see, though, no, it's important. There's an important social science point here. You'll see that there's been an uptick in satisfaction in airlines since 9/11. Now, what is that about? Well, it's an adjustment of expectations. We all know we have to turn up at the airport 2 hours early, and you prepare yourself mentally for the strip search and the flogging before you get on the plane. And that's an important point. Now, hospitals have been on a reasonable buoyant mood for the last 6 or 7 years, but we're starting to see some erosion. Why this is important? We work for, in our joint venture, work for every major pharmaceutical company, a lot of the major health plans, and the pattern that happened in the 1990s was a pattern of demonization of managed care. And this took about a decade, and you can see the demise in satisfaction with health insurance and managed care. Our clients and colleagues in the pharmaceutical industry are currently experiencing this. There's been a 35 percentage point drop in satisfaction over the last few years, partly because people have had to pay out of pocket for those products. And that's been a relative shift, and I'll come back to that point later. But it is at the stage now where managed care companies are equivalent to tobacco companies as the most despised in America. Which leads me to the strategic conclusion that Cigna should just go ahead and merge with Philip Morris. Now, what's important to understand here is that this matters. Demonization matters in 2 ways. One is it matters in terms of public policy, because if you are demonized by the media and the public, people want to regulate you and do nasty things to you. So the companies in our surveys, we ask who should be more regulated and who do you trust. They don't trust managed care, they don't trust health insurance, and they don't trust pharmaceutical companies. And, you know, they might trust hospitals, but they trust supermarkets more than they trust hospitals. So our friends in the hospital business should not get too carried away. The second thing that demonization does is force organizations to make changes in their private strategy. And that's happened with every managed care company. I work with Kaiser and Aetna and others. And they have all gotten out of the business. Kaiser, I would accept from this. They've gotten out of the business of saying no and into the business of saying you can have absolutely anything you want as long as you pay for it out of pocket. And that's the trend we're on, which is basically shifting the burden of payment increasingly to the consumer. And I'm going to come back to that theme throughout my remarks.